Dr. Rob Barkett Jr. is the author of Simple Medicine. No more Google searches, which provides practical, easy to understand answers to most people's medical questions. Dr. Barkett practices internal medicine in Mansfield, Ohio. This podcast is called Simple Medicine as well. And in our first podcast, we discussed behavior modification techniques to address type 2 diabetes mellitus. Specifically, we talked about the 4 Ps: pasta, potatoes, pastry, and panera, which we call bread. Today, we're going to discuss medicinal therapy. So the first question I have for you, Dr. Barkett, is what is your algorithm for drug treatment for diabetes today, and how is that different in the past?
Well, the medications that we have available to us right now are tenfold better than what we've had in the past. And I'm going to discuss today as if the hemoglobin A1C, which we discussed before, a sugar-coated red blood cell percentage, which measures the last 90 days average of your blood sugars, is 6.5 or greater, and the patient has failed the diet, the exercise, and the weight loss. So this is just your usual asymptomatic diabetic patient who now requires medical therapy. Now, A1C is per each doctor's discretion if it's what he wants to do, but I think a very simple algorithm that the guidelines show now, there's a little variation, but the first one should be first medication should be metformin. Metformin has been out forever. It was a breakthrough drug. It's taken once or twice a day, and it lowers A1C. It does not cause weight gain, and it does help reduce the risk of cardiovascular events.
So prior to metformin, what did you use, and what was it like to finally have access to metformin?
Well, metformin luckily has been there since I've been in practice for 30 years.
Okay.
You know, before it was, and metformin's very cheap. That's people like that, very cost effective, very cheap. But before they had like sulfonylureas, which we'll get to, which I don't like. And then we had insulin. And so we really, before I started practice, and then in the last 30 years, metformin was the first go-to drug. And then I'll get to some of the other drugs that have been invented, but we really don't use as much.
Sure. So we talk about metformin, and we've talked a little bit about the fact that it's been around for a while and what types of patients it's best for. How does it actually work? What does it do?
Well, metformin, it works basically in the liver.
Okay.
And the way it helps break down sugars, it helps preventing new glucose formation, and which does help lower your daily blood sugars. And it's fairly well tolerated, but if you're not going to tolerate, you'll get abdominal cramping and diarrhea, and if that starts, it's no coming back from it.
Okay.
And then metformin is also used in combination with some of the drugs we will talk about next. But I believe every type 2 diabetic should be started on and kept on metformin because of its cardiovascular benefits, mostly well tolerated, and it's cost effective.
So what is an SGLT2 class of drugs? What does that refer to?
That refers to incretins. The SGLT2 class, it's a bunch of new biological information that we were not well trained of. And if I always say thank God for the drug reps, because since there's not a lot of continuing medical education courses anymore, and I read some journals, but if it wasn't for the drug reps coming here and educating me, I probably wouldn't be up to date with this SGLT2 class. And this class of drugs is another hormonal class that works in the gut. And honestly, I look at the pictures and the diagrams and I'm confused by it at times.
Okay.
I understand it when I'm looking at the charts and could tell you, but the main way that this drug works, it does not allow the body to retain sugar, so you do eliminate sugar from your urine.
Okay.
So it gets rid of excess sugar, and with this excess sugar that it releases, water is drawn with it, and I think that's why it causes weight loss, these SGLT2s. And these SGLT2s are called, there's Invokana was the first one, and I think they kind of got, and then Farxiga, and then Jardiance. And you can fight over which one you want to use if it's on your formulary and the benefits. But the other benefits of this class, other than dropping the A1C, decreasing your blood pressure, weight loss, it's now been shown to help halt to progress kidney failure. And also, this class we are now using to treat heart failure patients that don't even have diabetes.
Interesting.
And we can combine this metformin with the SGLT2 class and call it Synjardy or call it Zigduo, where you get 2 pills in one. So this is also cost effective, and the insurances are finally seeing the benefit, and most of these are covered.
So as the body is eliminating sugar through urinary waste, is there any risk of crystallization or urinary tract infection?
Yes, there is. Great question. I should say the side effects. And the most common, and some people just hate it, but frequent urinary tract infections and yeast infections in women, and men who haven't been circumcised can get balanitis, which is an infection on the head of the penis. And
right.
I've had to stop in a few women because they get, their A1Cs went from 9.6 to 6.7. They lost 10 pounds, but I refuse to treat them like monthly for their yeast or urinary tract infection. So that is by far the most common cause. And you have to remember, because it causes a little dehydration, if you're on those medicines, you must stop them a day or two before any procedures or surgery, so you don't get a condition called lactic acidosis, which we don't need to get into.
No. Well, I'm sure we will one of these days. So we've talked about now 2 classes. When is insulin introduced as a treatment method?
Not yet.
Not yet. Okay.
So as you have said, the changing technology and the changing of medications, the other new class is called the GLP-1s, and it's really kind of similar as SGLT2 with these incretins and the way they're absorbed in the gut and the way they
is that like Trulicity and Ozempic? Is that
correct?
And you see them all over TV all the time. There's always a TV commercial for those 2 drugs.
Well, these 2 drugs are excellent also, and the main reason we're seeing them is because they do have some similar medicines, like the semaglutide is the name of the molecule, and then Ozempic came out, and then they came out with a weight loss drug called Wegovy, and across the nation people are getting it legally or illegally for weight loss, and that's why it's just huge across, and that's why we have a complete shortage of it now, and I can't even start it right now.
So if somebody were to be on Wegovy and they weren't diabetic, is there a risk that they would develop diabetes or not at all?
I would say it's probably, in that case scenario, it's very preventative.
Okay.
And what I like about this GLP-1 class, and some doctors will say, geez, once you go to metformin, your second line of defense could be these GLP-1s. These GLP-1s, I keep forgetting, they can be injected once a week.
Okay.
And there's also a GLP-1 combination called Mounjaro, that's come out recently. But with GLP-1s, there's also a medicine by mouth called Rybelsus, which again is semaglutide. And so I let my patients decide if they want to take another medicine daily or a once a week injection. And these drugs not only, again, decrease weight loss, decrease blood pressure, decrease A1C. Now these drugs are used to help prevent or decrease cardiovascular events. And they're also being used sometimes in patients with cardiovascular disease who we've run out of options.
Okay. So what I'm understanding from what we've talked about in this first segment is that the outlook is getting much rosier for people who have type 2 diabetes, are borderline diabetic, are hypoglycemic, or have weight loss that behavior modification simply will not address.
Absolutely, and it almost makes me think even non-diabetic, man, maybe I should better just take one of these pills.
You don't need the help. I might need the help. We don't know.
Are incredible, groundbreaking, and there is the risk of pancreatitis, and you can't do it if you have a rare family history of medullary carcinoma of the thyroid. But I've only seen the pancreatitis one time.
Okay.
And to answer your other question, there are other drugs, like what did we used to have? Sulfonylureas, glipizide, glyburide, amaryl, glimepiride. Cheap, lowers A1C grade, like 1.5%. But
Okay.
weight gain, which you don't want in diabetics, and the risk of hypoglycemia. And we'll get to that in the insulin, but we don't want anyone as physicians going too low, because then, there's nothing you can do. These drugs are long acting, and we don't want any seizures or, really low sugar reactions.
Okay, so we've hit 3 now. Are we at the end of the line, or is there a 4th one?
Other drugs by mouth that came out was the DPP-4s. Now, they came out after metformin.
Okay.
And we really thought that was awesome. In the end run, they didn't decrease risk of kidney disease or heart attacks or strokes, and they really had a modest, around 0.7 decrease in the A1C. But it was another option before we then would have to go to insulin.
Okay, so now we're at insulin.
Now we're at insulin.
So, what is insulin? Where is it produced in the body normally? And when it isn't produced properly, how do we get it into our body?
Well, type 1 diabetics, their pancreas just won't make insulin. So
Okay.
that's why that's a different animal. And type 2 diabetes, genetic predisposition, overweight, and the majority of people are insulin resistant. Their pancreas is just not making enough insulin.
Okay.
90% of the time, people are overweight and they have fat cells. And these fat cells, pancreas is making insulin, and these fat cells block other fat cells, skeletal muscle, liver for insulin where it needs to get to work. So it's kind of like you're trying to play football, you're trying to run the ball, and you have 4 or 5 blockers up front, and they have 9 blockers. You're not getting through the line.
No, you're not.
You lose weight, 10% of your body weight in a year. All of a sudden, you got 6 blockers and 4 defenders. You can run that ball. Insulin's going to get through. So what happens, people don't lose the weight. The pancreas overproduces. It floods the system to
Okay.
get where it needs. And eventually, like any organ, it wears out.
I see.
So the pancreas no longer can keep up. You've tried your other medications. The A1C is still not at goal, which I still like. And older than 65, about 7.5 on the A1C. Younger than 65, 6.5. And that's just, again, so we don't get into any low sugar reactions. We have wonderful new insulins, but insurances sometimes don't like these newer insulins.
Okay.
And that's called Tresiba and Toujeo. If you're not on these are the Cadillac of insulins because they are very long acting. They get into your system, they just kind of stay there. They're 36 to 42 hours in your system, and they don't produce low sugar reactions, which we love. Insurances still make us go back to the old Lantus or Levemir. They have about 12 hours they're in and out. They don't really cover the day. Sometimes you have to start giving these twice a day, and they do increase the risk of low blood sugar. And that's, where you get sweaty, shaky, confused, and like I say, sometimes the lights are on, nobody's home, and then they
Right.
go out, and you don't want them to pass out or have seizures or coma.
Right. Anything else that you want to address about diabetes before we shift topic? Because I got some other questions I want to ask you today.
I believe that's the highlights.
Okay.
And if I think most primary care physicians should be able to follow this algorithm. I don't think you really need an endocrinologist, but if all else fails and you can see an endocrinologist, go see them. Second pair of eyes for the patient, and they may need an insulin pump, which is continuous sugar. And the last thing I almost forgot, 2 things.
See, I knew there was something else. There's always something else.
First of all, CGMs, continuing glucose monitors. If anyone is on insulin, and the insurance paid for it. It's a little device you wear on your arm. You don't have to check your sugars, you just check your phone. And it's really good at patient education, because they're like, oh, I thought this was healthy. Oh, my blood sugar is 300. They're thinking, oh man, I cheated. Oh, it's 150.
Right.
Beautiful results with these monitors. Dexcom's one, the Freestyle Libra's another. And the other one, anyone on insulin should have a glucagon pen called the Gvoke. And it's a simple little pen, and if you have a low sugar reaction and a little bit of orange juice or a candy doesn't help, it's a simple injection, takes 5 seconds, and can prevent hospitalization or even death.
I see. The book is called Simple Medicine. It's available at Barnes & Noble and Amazon. It's also available, we're going to say that one more time, it is also available at simplemedicinebook.com, where you'll also be able to find our podcasts. Podcast is called Simple Medicine. This is Dr. Rob Barkett Jr., and we thank you so much for listening. We'll be back next week.